this, okay? Let's do this.
Love you.
Here we go.
In the UK, some 3 million major operations are carried out every year.
Just take some nice, big, deep breaths. I'll take good care of you.
But some patients' procedures are so complex, only the best surgeons can perform them.
We're okay to go.
Okie dokie. You do have to have resilience. We have death on our doorstep all the time.
Adam Brooks Hospital in Cambridge is world-renowned for its pioneering techniques to treat conditions that few others dare to take on.
You feeling brave?
We often deal with people at the extreme end of life. So during an operation, you're almost in the heat of battle.
But pushing the boundaries of modern medicine comes with great risk.
No margins for error here.
You have to accept that things will go wrong. Experience is learning from your mistakes.
Starting to split along where the stitches have gone in.
Every decision you make has direct consequences on someone's life.
She's not responding.
The surgeons bear the ultimate responsibility.
Oh no.
Quick, a lot of bleeding here. This is not working. What a bugger!
This is what really happens behind the closed doors of their operating theatres.
It all looks good.
Perfect. Mission accomplished.
There we go. Brilliant.
The patient is trusting you in a very difficult situation, and you just need to make sure that you deliver your part of that bargain.
With over 10,000 staff, Adam Brooks is one of the country's largest hospitals, offering specialist care to patients from across the UK. It also has the biggest organ transplant programme for adults in the country. 2 of its leading specialists are Iram Amin, the first female consultant transplant surgeon at Adam Brooks, and Neil Russell, the clinical lead for transplant surgery. The duo first met while studying medicine at Cambridge University.
Iram and I have known each other for a long time. We were at medical school together. We both had similar training and I think from fairly early on decided we both wanted to do transplant. So we've been colleagues for many years now.
Neil is a genuinely lovely person. He's funny, we have quite a lot in common, and knowing him for the last 20 years or so, he's like a brother to me.
Together, they've performed hundreds of life-saving operations.
I think the importance of making a good team is trusting each other.
It's very natural. I know exactly what he's going to do, he knows exactly what I'm going to do.
Their next case involves 2 patients and 2 major operations. A live donor kidney transplant. It's an uncommon operation. Fewer than 1 in 3 kidney transplants in the UK involve a living donor. What makes this case even more remarkable is a husband is donating a kidney to his wife. Tracy, 42, and Marcus, 44, have been together for nearly 20 years.
We're best friends. Everything she likes, I like. Everything I like, she likes.
What a stud. You both look quite serious.
A year ago, Tracy was diagnosed with end-stage kidney failure, and the best long-term solution is to have a kidney transplant. So husband Marcus had himself tested to see if he was a possible donor.
It just transpired that Marcus is my match. My husband is my match, which is quite unbelievable.
With more than 4,500 people in the UK waiting for a kidney, if Marcus hadn't been compatible, it could have been 2 years before Tracy got a kidney from a deceased donor.
It's very strange that we're a match, isn't it?
Yes, 1 in a million that we're a match. It's just...
Isn't it?
A lot of people say, oh, it just proves it's meant to be.
Postwoman Tracy was in her 20s when sustained high blood pressure caused her right kidney to fail. This also led to her remaining kidney function falling to 9%. so she needs daily dialysis, or she would die.
I have a catheter which goes into my belly, and then I attach myself to a bag of fluid which has been warmed up. It's a bit like a drip bag, and then it does this osmosis thing.
The dialysis fluid, containing glucose and electrolytes, draws waste products out of Tracy's blood, mimicking some of what her kidneys would normally do.
Everything in my life has changed dramatically. Being a post lady, so I'd be walking 10 miles a day. Can't do that.
Tracy's changed loads. Now, a fraction of herself, that's hard. It'd be hard for anyone.
Tracy and Marcus have 4 children.
Right, you ready?
And a 2-year-old granddaughter, Ophelia.
Can you get me the cucumber? Thank you. Can you put it on the side? You get the news, okay, it's happened. Let's deal with this. And as a family, we'll get through it together. Dinner, come on.
Recently, Tracy was found to have a problem with the electrical signals that make her heart beat. But after extensive checks, she's been declared fit for the operation.
It'll all be fine. It'll all be cool.
We're looking forward to having them back and healthy. Yeah. And... Yes, we are.
The plan is to remove one of Marcus's healthy kidneys and transplant it into Tracy in 2 major operations on the same day. Because the all-day surgical marathon is so demanding, Iram and Neil will be joined by Professor Mike Nicholson.
So Mike, you're taking the left kidney and we're going to have a look at the images.
A specialist in live donor kidney transplantation, Mike will perform the first operation to remove Marcus's kidney.
So we're taking the left kidney, which is what we normally do. It's our usual preference because the vein that drains the kidney is much longer on the left-hand side than the right-hand side in almost everybody.
First, Mike must free Marcus's left kidney from surrounding tissue and fat at the back of his abdomen. Then he must isolate and detach 3 vital structures: an artery and vein that take blood to and from the kidney, and the ureter, which carries urine from the kidney to the bladder. Then he must remove the kidney without damaging any of these structures or the kidney itself, so Tracy's transplant can go ahead.
I mean, ultimately what we're hoping for is that Tracy will be off dialysis and this kidney will last her over 20 years.
Marcus will be left with 1 kidney, enough to filter his blood and allow him to live a healthy life. But the operation he faces is not without risk.
And the issue is that there's a very high flow of blood through the renal artery and the renal vein. So if the stapler doesn't seal the blood vessel properly, but you can actually have catastrophic bleeding, which is potentially life-threatening.
I'm more worried about Marcus than what I am myself. He doesn't need to have surgery, so he's literally doing this just for me.
Hi, I'm Sarah Jane. I'll be looking after you today.
Hiya.
I'm just going to do an ECG, okay?
Yep, no worries.
At any point through this whole trying to match, he could have pulled out any time. But he hasn't. He's gone the whole 9 yards, just for me.
Something on the other side, darling. Got this, okay? Let's do this. And stop crying. Love you.
Love you more.
In Theatre 20, Mike is briefing the 11-strong surgical team ahead of the operation to remove Marcus's left kidney.
The patient is going to be on the table on their right-hand side with their left-hand side up. It will take about 2.5 to 3 hours.
Surgeons Iram and Neil will follow Mike's progress and prepare the kidney for transplant once it's removed from Marcus.
I was going to get you to walk through, but now that you're having a ride... Right, so I'm going to stick some sticky dots on your head. This allows me to see how deeply asleep you are. Starting to feel a little more relaxed?
I wasn't really worried.
No?
No. Been long awaited.
It's well planned for, isn't it? Yeah. Well planned for. Now, imagine yourself going to the Great Barrier Reef. You're going to go for an amazing scuba dive. Just breathe in and out and hear the bubbles of your gear. That's it.
It's not only about Marcus and making sure that he's safe. It's also about Tracy and making sure that we've removed a kidney and it's in perfect condition so that when it's transplanted, it's going to work immediately and work for many years in the future. Can we start, Tim?
Yes, please.
Thank you.
Hang back.
I think we try and convince ourselves as surgeons that we're not under pressure. It's a very controlled environment in which everybody knows what they're doing. And you're doing things that you've done many hundreds of times. It's a pleasant thing to be involved in, right up until the point where it goes wrong, when it's not pleasant at all. And you have to be ready for that, for something going wrong, or ready for the unexpected.
That diaphragm back, please.
Complex procedures to try and reverse debilitating conditions are at the heart of the specialist work done here at Addenbrooke's. For leading colorectal surgeon Consultations Similis, this involves a high-risk operation to allow a patient to resume his old life after more than 2 decades with a devastating bowel condition.
Colorectal surgery, yes, it doesn't sound glamorous, but you really need to be a good surgeon. You can really change someone's life, improve someone's life. Yes, it's very, very rewarding, yes.
Konstantinos's patient is 39-year-old father of 2, Danny, who suffers from severe Crohn's, a type of inflammatory bowel disease with no known cause that affects more than 200,000 people across the UK.
I was first diagnosed with Crohn's when I was about 15. I've always struggled with food and eating, and for as long as I can remember, and in my early teens would get sort of belly aches and nausea. Fill it up, get some water from here, pour it in.
2 years ago, Danny's Crohn's flared up so severely it caused his bowel to perforate. The leakage led to sepsis, which can be fatal. His only option was to have an ileostomy, where the small bowel is disconnected from the large bowel and brought to the surface of the abdomen through an opening called a stoma.
This is obviously a stoma bag, holds the waste. The hole is where the end of the bowel sticks through on my belly, and then just drains into the bag.
Danny struggles to put on weight because his ileostomy makes it difficult to absorb nutrients and fluids.
There's days where he's like, oh, I feel great, I could do all these things, I could take on the world. And then there's days where he's just, I don't want to do anything. I just want to sit here. It's difficult to see it. It's difficult to see that.
That's okay, put some more in.
Danny's condition meant he had to give up his work in electronics.
I often have low energy levels. I want to feel productive, I want to provide for the family, you know, but when you can't, it makes you feel useless.
Crohn's can't be cured, but biological drugs have brought Danny's symptoms under control.
I could pack this bag as well.
And with his weight stable at around 8.5 stone, Danny's been judged fit enough to have surgery to try to reverse the ileostomy and reconnect his small and large bowel.
It'd be nice not to have to be so close to the toilet 24/7.
Yeah.
A bit of freedom.
If successful, Danny will be able to resume the life he had before his stoma.
This is such an important thing. I think this is really pivotal. It's massive, big, big hope, I think, for him to just be able to have a normal life, just be able to do the things he wants to do.
While Danny is well enough for surgery, Konstantinos and Registrar Chi Ying Tan won't know if they can reverse the ileostomy, a procedure carried out just 26 times last year at Addenbrooke's, until he is open on the operating table.
And we're looking at the small bowel, which is here, and there's no evidence of bowel obstruction or stricture. Obviously, there is some information that is not available to us now and will become available to us during the surgery. We will need to have a very close inspection of that bowel to make sure it's a healthy bowel, make sure it's not affected by Crohn's disease. But I think this is a good time for Daniel to have his surgery.
Konstantinos needs to open Daniel's abdomen without damaging the small bowel, which could be stuck underneath with scar tissue from previous operations. Then Konstantinos must free the bowel and check that it's not been damaged by decades of Crohn's disease. If the small bowel is healthy and long enough, Konstantinos can disconnect it from the stoma and reconnect it to the large bowel. Then waste can pass normally through Danny's body.
Long wait for this.
Yeah.
With his wife Tej at home with the children, Danny is brought to hospital by his mum, Ted.
He says I'm a calming influence, but I don't know about that.
You are, because I know that anything that's making me nervous or anxious or anything like that, you explain it or you can help. It's definitely reassuring.
Good.
Hi, Mr. Simon, consultant surgeon.
Nice to meet you.
Hello.
Hello, I'm Mum.
Nice to meet you. I will ask you about the ileostomy. How has this affected your life?
The side effects of malabsorption, dehydration, my mood, my ability to think goes up and down.
Exactly.
It's a struggle.
We're saying that the benefits of what we're planning to do today outweighs the risks. And it may not be a life-saving surgery, but it's a life-changing surgery. And I know you've been waiting for a long time.
To me, it is life-saving. Yeah.
Yep. Yeah, and I know
Not
you've
in
been
the
waiting
direct
for...
sense, but in the indirect sense, yeah.
No, I understand that.
Yeah.
Okay.
Brilliant.
Okay.
Thank you very much.
You're welcome.
I think the quality of life improvement from this operation will be pretty great because I'll be able to do more with my kids, which is my main priority, and maybe even get back into work.
In Theatre 6, a team have assembled for Danny's 5-hour operation.
Hi Danny, welcome. Hi.
Welcome. Come through.
Close your eyes and hope you have some nice dreams. We'll take good care of you. See you in a bit.
Can we start?
Yes.
Thank you very much. I will exercise the scar.
scars,
You agree?
Danny's history of severe Crohn's and bowel surgery makes the operation high risk from the start.
Daniel doesn't have a significant amount of body fat. That creates a higher risk of damaging either the bowel or the organs surrounding the bowel because you don't have that fat protection. Can I have a right angle, please? Chi, hold this. So we have gone through the skin and now going through the fat. If the bowel is not healthy or me as a surgeon damage part of the bowel, there's a limit of how much bowel you can take out because then the patient won't have enough bowel left behind to be able to have a normal life. And that's a big weight on my shoulders as a surgeon. I'm using this clip just to try and lift things. Go for it. You can go for it. Just to lift things away from anything that may be underneath. Be careful, there's a bowel right there.
In Theatre 20, Professor Mike Nicholson has started the intricate surgery to remove Marcus's left kidney.
I think it has got some stress involved in it, is the truth. Marcus is a completely healthy individual. They didn't need the surgery in the first place. So if it harms them, it's really awful. So that is a pressure, actually.
Scissors, please.
And medium Langerbeck in a second.
Removing a kidney from a living donor used to require extensive open surgery. Mike was the first surgeon in the UK to use a less invasive method.
So laparoscopic or keyhole surgery has removed many of the disincentives to donating. It's easier for people. Because the cuts are small, the operation is less painful, you recover more quickly back to normal activities, including going back to employment.
Mike makes 3 small incisions, about 1 centimetre wide, to create 3 ports into the body.
Good musculature.
The first is used to pump carbon dioxide into Marcus's abdomen.
Okay, you can come out with those, Jack.
Gas
on.
Gas on, please.
Inflating it to create space for Mike to operate. Then a video camera is inserted that will give a highly magnified image of the inside of Marcus's abdomen.
Camera lights on, please. On a scope. Yeah, scope.
The other 2 are for the surgical instruments, which must be operated with controls at the end of long handles.
Something to grasp with. You don't have much sensation of touch, but also it's a 2-dimensional image of a 3-dimensional situation, so there's loss of depth perception. So you have to train to get used to those things.
The kidneys are at the very back of the abdomen. To reach the left one, Mike needs to carefully navigate around vital organs.
Now, is that colon down enough? The kidney has the bowel, the colon sitting in front of it, which is a tube, and that has to be mobilised and moved out of the way to get to the kidney. So whenever you do that, you can puncture the colon. It probably wouldn't be sensible to go on and take the kidney out in that situation for fear of infection. Where's the ureter? There.
As Mike exposes the kidney, he needs to be mindful of the surrounding blood vessels. Damaging them could not only cause a catastrophic bleed, but also deprive the kidney of the blood it needs.
You have to maintain the blood supply of the kidney right until the end of the operation, because the blood is taking oxygen to the kidney and keeping it alive. And that, I think, is gonadal artery down here, so I don't want to prang that.
Back on the ward, Tracy is doing one final dialysis.
I'm feeling very anxious. Obviously, I've not heard anything yet. Just want to make sure that Marcus is okay and everything went well for him. Then it'll be my turn and get it over and done with.
In Theatre 20, surgeons Neil and Iram arrive to check on the kidney they'll be transplanting into Tracy.
Hello.
Hello.
How are you doing?
So we've now done most of this section. What we've done is we've got the ureter here, draining from the kidney to the bladder. This is the renal vein. We've divided a couple of tributaries to get the whole length of it. And behind the vein is the artery. So now the kidney is almost free.
With the kidney exposed, Mike can start the final phase of the operation, removing it from the vessels that have been supplying it with oxygen.
Should we go and get some things on? Yeah.
The upper pole's looking a bit dusky. Oh no, that thing we divided it had to be divided there.
Suddenly, Mike notices the upper pole area of the kidney has changed colour.
The kidney is a red-brown colour when it's got a good blood supply. And if the blood supply to a part of it is compromised, then it changes colour and it becomes darker, which we describe as duskiness. What do you think? I'm worried I might have got the upper pole up here somewhere. The big worry is the duskiness might be due to the fact you've interrupted a blood vessel, but it's most commonly due to spasm in the artery.
Touching the artery could have triggered a spasm, reducing the blood flow through it. With a compromised oxygen supply, the cells in the upper pole area could be dying, and that part of the kidney might stop working.
Knife, please.
Now the priority is to get the kidney out, so Mike makes a larger incision in Marcus's abdomen.
Just get that one in there.
And carefully inserts an endo catch, which will deploy a plastic bag to retrieve the kidney, to reduce the risk of damaging it.
Hemlock clip, please.
He staples and cuts off the ends of the ureter that carries urine from the kidney to the bladder.
Can't imagine we'll need much ureter.
Scissors.
Looks great, Mike.
The renal vein.
Happy?
Happy.
And the renal artery.
Happy?
Yep.
Okay.
As soon as you do that, the kidney is no longer receiving any oxygen. And worse than that, it's still warm, it's at body temperature. So its oxygen requirements are quite high at 37 degrees C. So the kidney is removed as quickly as we can.
Scissors, please.
Yeah.
There you go.
Medium nice.
Now Iram and Neil need to work fast. Without a blood supply, the kidney's cells could start to die. They need to perfuse the kidney, circulate a solution through its blood vessels that's rich in nutrients and antioxidants that can prevent damage to its cells.
As soon as we're given the kidney, it's imperative to try and flush out the blood to stop it clotting in the kidney, cool the kidney down to reduce the amount of energy the cells are using, and also use a special preservation solution which tries to protect those cells while they don't have any oxygen.
So the upper pole is just taking a wee bit. Oh, it's cold.
But the solution is not clearing out the upper branch of the renal artery that could have gone into spasm. The danger now is any blood left inside it will clot, causing permanent damage to the kidney.
If you were to put that kidney as it is into the recipient, that part of the kidney would not work. So it's key that the kidney is fully perfused so that you get 100% functioning kidney rather than an 80% functioning kidney, because part of the kidney has essentially died.
Just watch the veins here.
Yeah.
We need to get a small cannula up into that blood vessel so that we can directly make sure that that fluid that's so vital to cool the kidney, to wash the blood out and to protect the cells is getting there.
But inserting the tiny tube into the blood vessel carries its own risk.
Yeah. Have you got that pink cannula?
Yeah, I've got it there.
The risk that we worry about is in trying to do that, we actually damage the main blood vessel and therefore we can make the situation worse. So we have to be very delicate in placing the tube, trying to get into that small vessel.
Like that upper pole,
So we found
there's a bit of kind of energy to the tissue around it, but nothing to the vessel itself. And I think that just went into intense spasm. That's why everything, the upper pole was a wee bit dusky. But we're perfusing it directly now.
Actually, it's better. It's not better for that bit's
Yeah.
improving.
No, it's clearing now.
Yeah.
That looks a lot better now, doesn't it?
Yeah. When I see the colour changing and the duskiness disappearing, it's a big sigh of relief, and you know that you have got 100% of the cells available to work.
It's a decent size, is it?
Oh, it's nice.
Yeah, it's
Because she's
perfect.
small, isn't she?
It's desperate to get tied.
With a healthy kidney now ready for transplant, Mike, Iram and Neil are halfway. Tracy's crucial operation is scheduled to start within minutes.
Although the kidney can survive without a blood supply, that time is finite. And despite the use of the preservation fluids and the cooling of the organ, we still are against the clock.
Now I'm just going to pass it to Gemma.
Cover it up nicely, Gemma.
Thank you very much.
We know that as time passes, there is damage happening to the organs, so we do want to get these organs in as quickly as possible.
Every transplant relies on the careful matching of donors and recipients to reduce the risk the organ is rejected once it's implanted. Graham Knighton is one of around 20 healthcare scientists at Addenbrooke's, whose vital work enabled more than 300 transplants, including heart, lungs and kidneys, to go ahead last year.
We need to find organs that the patient's immune system won't attack and won't cause rejection to.
Matching starts with detecting antibodies in the patient's blood, proteins that mobilize the immune system to attack foreign substances. They're compared with antigens, proteins on the surface of cells that may be targeted by particular antibodies, belonging to 10,000 deceased donors whose varying tissue types are representative of the UK population.
These antibodies on the left represent the highest risk of rejection, and these over here on the right represent the lowest risk.
Testing here showed that Tracy had antibodies against 50% of the population, but crucially, none against Marcus. Once a potential donor is identified as low risk, their blood is taken for a cross-match test.
Have separated out beautifully with the red cells at the bottom, the lymphocyte layer, the plasma at the top, and then this cloudy layer are the white blood cells, and those are the cells that we're interested in.
On a cross-match plate, the recipient's serum, containing antibodies, is combined with the donor's white blood cells, rich in antigens. If they're stained green, the recipient's immune system hasn't destroyed them.
The cells are alive, and that means that the transplant can go ahead.
It's a successful match of organ donor and patient that would allow a transplant to go ahead.
Transplantation is an incredible gift, and what we do is assist in the journey of the giving of that gift, and it's a great thing to be a part of.
In Theatre 6, Konstantinos is about to discover whether the condition of Danny's bowel will allow him to attempt to reverse his ileostomy.
Okay, go on my finger. So what we have done is that we have managed to go through all the layers of the abdominal wall, and now I have my finger here, and my finger is here to making sure there's no bowel adherent just under the abdominal wall.
Before Konstantinos can investigate the full extent of Danny's bowel, he needs to remove adhesions left by previous operations.
Adhesions is scar tissue similar to glue. It makes the bowel stick to each other. This is what an adhesion looks like, and you can see this is like, it makes these fat layers adherent to each other. And we can safely take that away because there's no bowel next to it. One of the main things is to be able to take this scar tissue away, to be able to inspect the small bowel, to make sure that Daniel has enough length of small bowel, being able to safely join the bowel back together. We're going a bit faster and we're a bit more confident because we have good view. My hand is inside the abdomen and we know we're protecting everything that's inside. So actually the situation is quite good situation to be.
More favourable than I imagine.
It is. Can I have the extra large Alexis?
To get a good look at the bowel and scar tissue, Konstantinos uses a large retractor to open up the wound.
You're strong today, Chi.
It's easier doing it this way.
Is it?
Yeah.
Obviously, you know what you do.
I learned it from a pro.
We don't know how much scar tissue we'll find, and we don't know how difficult it will be. Let's start from here.
If there's too much scar tissue to cut away, the operation will have to be abandoned, and Danny will be left with his stoma for life.
Scissors, please. So that's where the stoma was. You hold that and let's start. So we're gonna start taking the adhesions out. So tissue scissors, please. Yep, thank you.
Progress is painstaking.
Stay as you are, Chis. You're in a good place.
Konstantinos and Chi must avoid damaging the vessels that form the bowel's blood supply.
I have to say it's good, Chi, because it's not very hard. It's soft. It's soft adhesions, which is good. I mean, you can see, it's a Crohn's disease bowel, but it's healthy. There's no active disease.
Almost an hour into the operation, and the first hurdle is finally cleared.
And the adhesions actually is very limited adhesions, which is very good for the patient, very good for Daniel. We found less adhesions than what we expected, less scar tissue.
It's a promising start, but now Konstantinos needs to establish whether Danny has enough healthy bowel to proceed.
10, 20, 30. It should be pink in color, with a good blood supply. You should be able to see the tiny blood vessels that take the blood there and take away the nutrients. It should be soft, and it should be fully mobile.
For the surgery to go ahead, Danny needs at least 150 centimeters of healthy small bowel.
80.
Normally, it's around 300 centimeters. But Danny's small bowel is shorter because unhealthy sections have been cut away before.
140. 150.
Only now, with Danny open on the table, can Konstantinos be sure he can attempt to reconnect his small and large bowel.
250, let's go for that. If you put on the board 250. We did not find any area of active Crohn's disease. That will allow us to maintain the length of the bowel that Daniel has at the moment, which is important because it allows us to proceed safely with the surgery. Now we're ready for the anastomosis, small bowel to large bowel. We're progressing very well.
There's one final hurdle to cross if Danny is to resume his old life.
The joint of the bowel is the most risky part of the operation for Daniel. Is he going to be able to heal afterwards? If there is a leak, it will be stools, feces inside Daniel's abdomen. That will cause severe infection, and that is life-threatening. We will need to take Daniel back to theater, clean the infection, remove the joint of the bowel, and then he will have a stoma as he has now. That would be devastating for Daniel.
With her husband Marcus's left kidney successfully removed, Tracy is on her way to surgery to have it transplanted.
You get him his kidney?
Yeah.
That is amazing.
Yeah.
So you're a perfect match.
Yeah, that's what I mean. That's why I'm so emotional now, because like he's done his bit. He's done it.
It's an amazing thing, though.
Yeah.
Around an hour and 40 minutes after Marcus's kidney was removed, it's now anaesthetist Tim Baker's job to put Tracy to sleep.
So what we do, we'll get you to jump over onto the other bed.
Okay.
Then I'll put the drip in. All right. The role of an anaesthetist, most people think, is to keep somebody asleep. Lie down first, but I might need you to shuffle up a little bit. Yeah, can you shuffle up a bit more? Most anaesthetists and surgeons would say the role of an anaesthetist is to keep a patient alive and be prepared to treat anything that arises unexpectedly. This is just oxygen, but I'll give you the medication in a second that gets you off to sleep, all right?
Because the donated kidney currently lacks a blood supply, surgeons Iram and Neil are working against the clock.
Are you good to go? Good to go. Yeah.
But just as the first incision is about to be made,
no, something's changed in there.
The electrical signals in Tracy's heart muscle have gone out of sync.
But she's highly irritable.
Okay.
My greatest concern is that Tracy will go into a cardiac arrest. Her heart will stop beating.
Tim gives Tracy magnesium, which acts on the cardiac cells to try and help stabilize the electrical signals in her heart.
I'm just seeing if I can get the rhythm to settle down a little.
With her heart's electrical signals still abnormal, the operation is halted.
Guys, can we just have a blanket and cover her over to keep her warm, please?
Under normal circumstances, when you induce a patient, send them off to sleep. If their heart rhythm changes dramatically, the first thing you do is question whether or not to proceed with the operation. Most of the time, you'd probably stop, wake them back up, and do the surgery another day.
But for Tim, stopping Tracy's surgery is not so straightforward.
Her husband has already had an operation. We've taken a kidney from him, and we need to put it into his wife in the next couple of hours. Otherwise, we've caused significant harm to her husband, but for no benefit to anybody. I'm responsible for making sure that she stays alive, but I'm also responsible for making sure that we do the right thing for both her and her husband.
The intermittent problem identified before the operation, with the electrical signals in Tracy's heart, appears to have been exacerbated by the anaesthetic.
There are quite a few factors why Tracy's heart has behaved like this, all relating to her kidney disease. Her high blood pressure changed the structure of her heart. The lack of kidney function has increased the amount of acid in her body and changed the chemicals that are responsible for maintaining the electrical stability in the heart.
If her heart problem can't be resolved, the transplant will have to be abandoned.
Just make sure there's nothing else that we're missing there.
Whenever your anaesthetic colleagues are coming across an unexpected situation, you want to support them. You don't want to put them under pressure. The worst thing you can do as a surgeon is kind of be stomping up and down saying, when can I start my operation? You're part of a team.
She's gone back to sinus now.
The electrical signals in Tracy's heart are now back to her normal, or sinus rhythm.
What did you do for it to flip?
Good dose of magnesium running through. Certainly looks better now, doesn't it?
Yeah.
Although the magnesium has helped stabilise Tracy's heart for now, Tim wants a second opinion from another anaesthetist about whether to proceed with the transplant.
She's now back in a sinus rhythm. Nothing electrolyte-wise, really, apart from her calcium is a tiny little bit low. Yeah, all right, thank you very much.
Happy?
Yeah, he agreed.
Are you happy for us to start?
Yeah,
okay.
After a delay of 45 minutes, Tracy's life-changing transplant can start.
There's huge relief that we can go ahead with it. However, it does add extra pressure to make sure that everything goes smoothly from a surgical point of view, because you don't want to put any more pressure on the anaesthetist who's already kind of in a situation where the risks have been increased somewhat.
Iram and Neil won't be removing Tracy's diseased kidneys, as they don't pose an infection risk and would make the operation even more complicated. Instead, they will place her new kidney in the lower abdomen, where they can access blood vessels to give the organ a good blood supply. Here they must expose the left internal iliac artery and the left external iliac vein before putting the new kidney in place and attaching its renal vein and artery to the exposed vessels. Finally, they need to connect the kidney's ureter to Tracy's bladder so urine can pass from one to the other.
So this is, I think, the anterior branch of the... So I think we'll take that once we've got...
Yeah.
Or go in there once we've got the retractors in. Are you happy to... That's it.
Yeah, that's good. So again, the common iliac artery is a nice size. Again, slightly irritating vein coming off the external iliac vein.
More than a pint of blood passes through the iliac vessels every minute. Any damage to them could not only jeopardize the transplant, but also cause a fatal bleed. So they need to be clamped off around where the connection will be made.
Right, so that's vein clamp on. So we're just clamping up the external iliac vein.
Now, Iram and Neil can start the most crucial phase of the transplant, the anastomosis, connecting the new kidney to Tracy's vessels.
Okay, so we're about to make a hole in the external iliac vein.
Hepsal, please.
Right, we just need to cut it a bit more, actually. Right, so I'm going to go up and down a little bit.
Yep. Looks good to me.
So if you bring the kidney...
We're ready for the kidney, yeah.
Right, so...
Well, it's possible we've got to keep the kidney cold, so if it starts to get warm, it'll start to get damaged.
The kidney has been stored at 4 degrees Celsius, which helps keep its cells alive. It's wrapped in gauze soaked in ice fluid to keep it cold while it's implanted. But it will only remain healthy if its delicate vessels can be connected without damaging them.
Renal vein, renal artery. Make sure the renal vein isn't twisted. You have to respect the blood vessels and know that if you are not careful, if you are not precise, if you are not accurate, you can tear the renal vein and you can get catastrophic bleeding, and you are not able to transplant the kidney if there is a catastrophic injury to the renal vein.
So if I go, shall I do my side first?
Yeah.
Because you're going to have the artery your side.
Yeah.
So if it lifts up.
Do you want to?
Yeah, she's doing that.
So I give you that.
Yeah, do you want to take the kidney?
Yeah, I'll take the kidneys.
Iram and Neil must work quickly. Every second the kidney warms, its chances of becoming damaged before it's connected increase.
So just attaching the renal vein to the external iliac vein. Inside the kidney, toxic substances and metabolites are building up, and this can cause damage to the cells of the kidney, and some of them can die. So suturing in the vein and suturing in the artery, ideally we would like to get both things done as quickly as possible. So we're now starting the arterial anastomosis. I'll do the middle one first and I'll do that. His artery is lovely. It's very nice and delicate. This anastomosis needs to be watertight and done in a technically precise way so that afterwards there is no clot that forms at the anastomosis or in the blood vessel as a result, because this will lead to loss of the organ. Just let me know when you're going to let go.
So what stage are you at now and what have you got left to do?
So Neil's just done the final suture. About to finish. Can we have some more flush, please?
Okay.
That's the last one.
Yeah, this one's going to be the last one. No foot pressure on the
No
last lot
pressure,
time.
no pressure, Mr. Russell.
With the renal artery and vein now attached, Iram and Neil's work will be put to the test. When the clamps are released, blood should reperfuse the kidney to give it life.
So reperfusion for us as transplant surgeons is both the most exciting part of the operation, but also the most concerning part of the operation, because if you haven't done the join properly and the blood tracks up within the wall of the artery, then that can mean disaster and the blood supply to the kidney not working.
The kidney is pale because it's been without a blood supply. That should change as it reperfuses.
Off you. And there you go. Nice and pink.
My favourite part of this operation is when you release the clamps and the kidney reperfuses. So you have something that's sort of very grey, browny looking, and suddenly it's pink and it's alive.
And that's a beautifully perfused kidney. Looks good, and the artery looks good from my side, How does it look from your side?
Yeah, no, it's lying really nicely, and that upper polar looks good. I can feel a nice pulse in it, actually. Yeah, it's good.
So the kidney's working already, which is always never fails to amaze us when it was in somebody else. Brilliant. Okay.
Neil and Iram can now attach the new kidney's ureter to Tracy's bladder so she can pass urine normally.
So I'm just closing this wound with stitches that will dissolve, so they won't need to come out.
To be part of this is quite humbling, really. The real kind of heroes of this day are the people who donate organs. So in this situation, Marcus to donate his kidney to his wife, but to be able to be a conduit in that area to help somebody cure their loved one, it's a really special position to be in.
Yeah, this is one of my favourite operations. I love it every time I do it, and it's just amazing. You know, this person's been given the gift of life from something very selfless. And yeah, it will never get boring or old.
You're going to feel very spaced out for probably the next half an hour or so. Are you comfortable? Yeah. Good.
Unlike Marcus, who could be back to work within weeks, Tracy will need several months of recovery and also medication for the rest of her life to minimize the risk of her immune system rejecting her new kidney.
How are you doing? You all right?
In Theatre 6, colorectal surgeon Konstantinos and registrar Chi are about to attempt to reconnect Danny's bowel, so he no longer has to use a stoma.
Let's put a small bowel here. So this is the small bowel that we're going to use to join the bowel. And this is the large bowel. Okay, that's perfect. That's what we're going to use to make the joint.
Rather than connecting the two ends of the small and large bowel, Konstantinos is using what's called side-to-side anastomosis.
There's different types of anastomosis. We know in patients with Crohn's disease that if we perform what we call a side-to-side anastomosis, the diameter of the joint is bigger. And by having a bigger size of this joint, prevents any complications in the future.
That's great, thank you very much.
A bigger joint is less likely to get blocked if Danny's Crohn's comes back. To make the join, Konstantinos needs to line up the ends of the small and large bowels side by side. Then, using an anastomosis stapler, he will cut through each bowel, creating a channel, or lumen, between the two sections. With Danny's bowel reconnected, Konstantinos can finally seal off the end using a staple.
Staple across, just above my fingers.
Happy with that?
Yeah, I think it looks good, okay.
So they can be joined, Konstantinos prepares the ends of the small and large bowel.
Well done, everyone. Stay as you are. I will fix it.
The join must be perfect. Any leak could cause a life-threatening infection and return Danny to life with a stoma.
That would be devastating for any patient. The stress to the body, the stress to the mind, the psychological impact of having such major surgery without any benefit, that would be terrible for Daniel.
We'll stay behind my staple.
Making the join is so complex, involving several instruments, that Konstantinos, Chi and the surgical nurse must work together in lockstep.
So Chi, you're gonna take this one in your hand and this one in your hand.
Yeah.
Sister, I'm gonna ask you to take this one in your hand and this one in your hand.
First, the large and small bowel are lined up side by side.
Turn with me. Always stay behind me. Stay behind me. Stay behind me. Now exaggerate and come in front of me. Come in front of me. That's right. Well done. Come more in front of me, all the way in front of me. Stay as you are.
The lumen, or channel, has been cut between the two bowels.
TA 60, please.
60 ready.
Thank you very much.
Before Konstantinos can use the second stapler to seal the join, any excess bowel needs to be trimmed away.
And give Chi a knife. Not too much tension, Chi. Leave it come to me a bit more. It's fresh, okay. So it is fresh, Chi. Thank you very much, okay. Exactly things as they are now, but let's put fresh swabs.
Stapling the ends ensures the join is completely sealed. Konstantinos needs to check for signs that it's going to hold.
That's the joining of the small bowel to the large bowel. We like to see that there is a good blood supply all the way to the edges. No tension, so it's fully mobile without any tension at all. Side-to-side anastomosis, that's where the joining is. So I'm just going to carry on putting sutures onto the staple line just as an extra reinforcement. Basically, it just takes some of the... Okay. Mission accomplished, stoma reversed. Thank you very much. Thank you as always, thank you.
Danny's bowel is now reconnected.
Until you see the patient being healthy, without any complications, eating and drinking, opening bowels, I think that's the only time a surgeon can relax and say, I did the right thing for the patient.
Tracy is back on the ward, and with Marcus's recovery going well, the couple can be reunited.
Come on, old man. How you feeling?
Good.
Well, you don't look good. You don't really like hospitals, you don't do needles. You just had major surgery for me.
Well, I can feel a void.
Oh, do you feel a little bit empty?
Feel a bit lopsided in my life outside.
Oh, I would say thank you, but there's no thank yous in the world that I wouldn't be able to say it enough times. There's just literally no words can describe what you've done for little old me. Oh, don't get emotional. Darling, you saved me. You saved my life.
Just how I feel.
Just emotional about it all. But thank you.
One thing about transplantation is that it's happy surgery. Nobody's come to harm that day. It's not kind of cutting out a cancer and hoping it doesn't come back in somebody. We're giving somebody a life that they were struggling with back. And it always feels like happy surgery.
Thank you.
Two months after his surgery, Danny is rediscovering normal life.
Definitely a lot happier than I was. It's nice to get out and about with the kids again. Have a bit more energy to play with them than I did.
Seeing Danny playing with the kids is joyful. I'm much more active and just feeling able to do it.
After 2 years with a stoma, Danny's now eating 3 times a day, drinking regularly, and passing waste normally.
Before the operation, I was struggling with my hydration quite a lot. But that seems to have calmed down massively now. I'm not constantly thirsty anymore. I feel a lot better in myself.
With his Crohn's in remission, Danny hopes to gain weight and set up his own business.
And it's nice to be in a position where I can just move forward in my life.
I can do it like this or this.
I'm just looking forward to just being a normal family.
I'm pleased that Daniel had his stoma reversed. We managed to improve his quality of life. And it comes down exactly why I love being a surgeon. It's a privilege to be in this position where you can have such a big impact on someone's life.
Come on, Talia.
Next time, major surgery to remove 2 tumours.
It kind of feels like someone's clawing at the inside of my head.
Growing near the spinal cord.
We need to fix it, please, guys, because we've got some bleeding now.
But a major bleed puts the operation at risk.
What a bloody bugger!
If we can't control the bleeding, that's it. You know, you'll die.